Welcome to the February 2023 LACNETS educational event. I'm Kavya Velagapudi, Executive Director of LACNETS.
I'm Lisa Yen, Director of Programs and Outreach for LACNETS.
And I'm Heather Davis, the Associate Director of Advocacy and Outreach at LACNETS.
Today's presentation is on genetics of NET. Do I need genetic testing? Thanks to our speaker, our LACNETS team, and Rich at TVP Live for this program. A special thank you to our sponsors, Ipsen Advanced Accelerator Applications, ITM Pharmaceuticals, and Lantheus. You may have noticed LACNETS now has a new logo, a new name, a new look, and a new website. LACNETS has rebranded as Learn Advocate Connect Neuroendocrine Tumor Society in late 2022. LACNETS was previously known as Los Angeles Carcinoid Neuroendocrine Tumor Society. LACNETS is now one of the largest NET patient and caregiver advocacy groups in the country. 80% of those reached by LACNETS live outside of California. Of those, 15% live outside of the United States. The new LACNETS name and logo establishes us as an inclusive national and international organization. Now to you, Heather.
Thank you, Kavya. This webinar is being recorded and can be viewed on the LACNETS YouTube channel shortly after this broadcast. Our YouTube channel features over 280 videos. Use our playlist to find webinars on imaging, PRRT, nutrition, liver-directed therapy, PhioPara, our annual conferences, guided meditations, and patient stories. Follow LACNETS on social media to stay up to date on our upcoming webinars and NET news. We are on Facebook, Twitter, and Instagram with the handle @LACNETS. And be sure to add us to your safe sender email list. I'd like to remind our audience that LACNETS webinars are created for educational purposes only and do not substitute for medical advice. The views shared in this webinar are the personal opinions of the experts. Please contact your medical team with questions or concerns about your individual care or treatment. And now I'll hand it back to Lisa.
Thank you, Heather. I'm pleased to introduce today's speaker, Samantha Greenberg. Samantha is an assistant professor and genetic counselor at UT Southwestern. She received her master's degree from the University of Michigan for genetic counseling and public health after teaching 7th grade science in Tulsa, Oklahoma. In her previous position, Samantha co-directed the recently named PhioPara Alliance Clinical and Research Center of Excellence at Huntsman Cancer Institute and High Risk Prostate Clinic at Huntsman Cancer Institute alongside a multidisciplinary team. Her research and interests center around prostate cancer genetics and paraganglioma and pheochromocytoma. In her new role at UT Southwestern, she is leveraging these interests alongside her passion for education, where she is developing a genetic counseling training program. I had the honor of meeting Samantha in Prague at the 2023 International Symposium on Pheochromocytoma, and I'm also acquainted with her on Twitter, where she is very active. It's clear Samantha is passionate about genetic counseling and helping people, and she is also a gifted communicator. We're excited to have Samantha Greenberg join us today to discuss genetics of NET. Do I need genetic testing? Welcome, Samantha.
Hi everyone, my name is Samantha Greenberg. I use she, her pronouns, and I want to just acknowledge that this presentation is coming to you from Utah, where we reside on the land of the Goshu and Eastern Shoshone people. We are uninvited inhabitants of this land, and we want to pay our respects to the caretakers that came before us. I'm really excited today to be talking about the genetics of neuroendocrine tumors and what genetic testing looks like. And I want to just break it down by first telling you what a genetic counselor is. For some people, this may be the first time that you've heard of a genetic counselor. Others of you may have somebody that you've worked really closely with. Genetic counseling is a process where we work with patients to determine if their personal or family history of tumors is suspicious for hereditary cancer syndrome. I acknowledge that not all hereditary cancer syndromes, right, necessarily put you at an increased risk for cancer. There can also be other increased risks, right, for neuroendocrine tumors or other tumors. And as a whole, the genetic counseling process is really to evaluate anything that falls under cancer care, whether it's a tumor or otherwise. Typically, when we meet with patients, genetic counselors are going to walk through your medical history, your family history, and then really think about your history, the history in your family, and what kind of conditions could be associated, and if genetic testing would be beneficial. From there, they're then going to walk through a plan to disclose the results and also think about what we need when it comes to coping and such. When we think about genetics, it can often be a tough topic, and we really work alongside patients and families to help them adapt to new information in this realm as well. So that's enough about genetic counseling. Let me walk you through just a brief Genetics 101. Depending on how long it's been since you've learned this topic, I just want to make sure we're all on the same page for some of the terminology that I'm going to be using. When I talk about genetics, I actually talk about making cookies. And while that seems like a weird analogy, I'll walk you through it. Our genetic code is made up of 22,000 recipes, and I think about it like a cookbook. Now, within that cookbook, or within those 22,000 recipes, all of them are genes or specific codes that make up who we are. Our hair color, how tall we become, whether our body can fight cancer kind of naturally or not. And what happens is that our recipes then code for proteins that you can see here below. So we always think about that genetic code coding for proteins that make our body who we are. And at the end, we think about those proteins similar to cookies. So that process, if you think about reading genetic material, if there's a misspelling or something happens that a large chunk gets added or missing, the body isn't able to make proteins exactly like it should. In the cookie realm, think about having peanut butter chips instead of chocolate chips. Sometimes you don't really notice the difference, right? Many of us may not mind if there's peanut butter chips instead of chocolate chips in our cookie. On the other hand, if there's a misspelling in that recipe, and instead of having flour, we have 2 extra servings of sugar, our cookie isn't going to turn out how we want it to be. And in the same way, the proteins in our bodies aren't able to code and instruct our body to fight against cancer or have a certain eye color, etc., like we would expect. And so what we do in genetics is really try to help identify if somebody has a genetic change that might put them at increased risk for cancer or change affecting something in their health. So when we think about tumors, and I've talked all about genetics, all tumors are genetic, but they're not all hereditary. Most tumors are just made up of a number of genetic changes that lead that tumor to become different than the cells that were originally in the body. On the other hand, not all tumors have an inherited change or hereditary marker that made it what it is. If you look at this chart, you can actually see that 75 to 80% of tumors or cancers as a whole are sporadic. They happen by chance. Now, there's about 15 to 20% of tumors that are familial. We see patterns of cancer or tumors in the patient and or their family that we think look familial. Maybe there's some kind of increased risk based on something going on in the family. And about 5 to 10% of the time, we can find a hereditary cause. This is where we find a genetic change that we think puts people at increased risk for cancers or tumors. And this is the area that we work in as genetic counselors. So we primarily work with people who have suspicion for something familial or hereditary to evaluate whether it is. So I want to take a second and provide one more analogy to think about how tumors develop and how we think about tumors that are sporadic and tumors that are hereditary. In sporadic tumors, I like to think about them like brakes on a bike. We get 1 copy of each gene from our parents, and therefore we have 2 copies of any gene that might be helping our body fight cancer or tumors. What happens over time due to age or just the body naturally making mistakes is that 1 copy of that gene has a misspelling and it stops working. And just like brakes on a bike, you can ride a bike with only 1 brake. You might just not feel quite as safe, and you might be more likely to crash, right? There's a benefit to having 2 brakes on a bike. Over time, maybe the 2nd copy of that material stops working. And now you have no brakes on your bike. And that means that the body's going to continue to work like it should, but at some point, if the cells start to grow and divide out of control, there isn't anything to say, nope, stop, we don't want that to happen. Similar to riding a bike, you can ride a bike with no brakes, but you're at a much higher risk of something going wrong, especially if you end up on a hill or something like that. And so once our body doesn't necessarily have those copies to protect us from developing tumors or cancer, we end up at a higher risk for developing cancer. So this is a process that people go through when they have just a tumor that happens by chance. On the other hand, if someone has a hereditary tumor, they're born with 1 copy of that gene not working, or in this case, with only 1 brake on their bike. And what that means, as you can see here, is that there's one less step in the process. And it's much easier for them to have a process that leads to the second copy not working and ultimately cancer developing down the road. And so these are the reasons why we think about identifying whether something is sporadic or hereditary. It not only helps us understand where a tumor came from, but it also helps us get a sense whether other people might have that increased risk as well. So we've talked a lot about sporadic versus hereditary, but let's talk about what it means to have a hereditary finding or a genetic mutation. Positive genetic testing results, or having a genetic mutation or a pathogenic variant, those are three different terms that you might hear tossed around to all mean the same thing, have three different impacts. The first is on treatment. So there's a number of different tumor types and genetic changes that can result in specific treatments being recommended. If we think for those in the paraganglioma space, similar to how we have a specific scan that can identify if a Zedra treatment might work for a patient, there are other genetic markers that can tell us whether a treatment might work better or not for patients with specific tumor types. We also know that when we think about a hereditary condition, we're not normally talking about just one risk for tumors. If someone has one type of tumor, they might have an increased risk for other tumors as well. And so we can be proactive in thinking about being preventative and or proactive when it comes to identifying future tumors. So the third one then is family. We know that when someone has a genetic mutation that puts them at increased risk for tumors or cancer, there's a 50-50 chance for family members to have that same genetic change and therefore have the same increased risk for tumors. Now we call this autosomal dominant inheritance because most of the time, as you can see here, each person has 2 copies of each gene, and if someone has it, there's only a 50-50 chance that other relatives in the family may have that same genetic change. This doesn't guarantee that somebody's going to develop tumors. It just means that they have an increased risk because they have inherited this genetic change. It's also important to note that not all conditions are autosomal dominant and have that 50-50 risk. But before I go down the rabbit hole into identifying those conditions and such, I think it's just safe to say if you find yourself needing genetic testing or have a concern about having a genetic mutation, finding a genetic specialist who can help you navigate this process and walk through inheritance for you is going to be your best bet. So this is the NCCN, or the National Comprehensive Cancer Center Network guidelines. And these are really beneficial because this is what we use across many institutions to make decisions. And most recently, about 2 years ago, NCCN came out with specific genetic guidelines for people with NETs or adrenal tumors. And you can see them listed here. I'm going to show them again in just a second. But what I like about this is that anytime there's an NCCN guideline, this really helps inform insurance and other providers about how we really need to manage care, specifically when it comes to genetic testing for neuroendocrine tumors. So I'm going to break all that down into a much more visible slide. These are all of the types of neuroendocrine tumors and or adrenal tumors that are currently recommended to undergo genetic evaluation and testing. If you have a diagnosis of a paraganglioma or pheochromocytoma, adrenal cortical carcinoma, gastronoma or a type 2 gastric NET, any kind of multifocal pancreatic neuroendocrine tumors, and then some additional tumors, parathyroid adenoma or hyperparathyroidism, so elevated parathyroid function, as well as tumors with suspicious findings on somatic testing, which I'm going to talk about in a second because that's a little bit out of the NET range potentially. And then lastly, there's some new consideration for anybody with a duodenal or pancreatic NET at any age. And what I think is beneficial to note is that when you have recommendations, those hold a stronger bearing than considering. So if you are someone who has a duodenal or pancreatic NET, this might be something to talk to your doctor about, but know that the guidance and the evidence for this is not as strong as for those with the tumors listed above. It's also worth noting that if you're listening to this presentation and you know that there is a genetic condition or hereditary risk in your family, you should also be undergoing genetic evaluation. So I want to talk a little bit about somatic testing because I think that this is really beneficial to understand that you might be getting lots of different types of genetic testing during your NET process. So the type of testing that we do to identify if there's a hereditary cause is germline testing. This is where, again, we're looking to identify if somebody had a predisposition or a risk that they've had since the moment they were born that put them at increased risk for this tumor. On the other hand, people may also have somatic genetic testing or tumor genomic profiling. This is where we're actually looking at the tumor itself to identify the genetic changes that led that tumor to be what it is. If the germline is where our cells start, the somatic tumor genomic profiling is where that tumor is in the moment. And that helps us identify whether there might be specific treatments or other options for you as a patient. It's important to note, though, that when we're doing this tumor genomic profiling, we can find germline mutations or those pathogenic variants or hereditary risks. And that's because, again, all tumor genetic material started as germline or natural kind of genetic code in your body. And so sometimes you might see maybe a BRCA or a BRCA mutation in the tumor that also exists as a hereditary risk. I'm not going to talk a lot about BRCA or BRCA genes, but you may be familiar with them due to a number of kind of celebrities or television shows, et cetera, that talk about them. Or you may have a family member or friend that has a strong history of breast and or ovarian cancer in the family. People with BRCA mutations have an increased risk for breast, ovarian, prostate, and pancreatic cancer. And sometimes we can identify those risks, as I mentioned, that someone has those increased risks from profiling the tumor. So it's possible that you might undergo a tumor profile that identifies one of these, and important to note that this would be another reason to really work with a genetic specialist and make sure that you're working through not just the genes associated with an increased risk for NET, but possibly things that might be found in your tumor as well. Of note, only 5 to 10% of tumors have a hereditary cause, so most people will have totally normal tumor genomic profiling, but we do see this happen, and so I want to bring it up as an option. This is one of my favorite tools. So this also comes from NCCN, and this is just a brief overview of the different conditions associated with NETs and other endocrine tumors. What's important to note about this is that if you wanted to go look this up yourself, you're more than welcome to. NCCN guidelines are at no cost. You just have to sign up for an account, and you could look at this as well. So if this was something that you wanted to get into, I'm going to give a brief overview, but I do just want to note that this is a publicly accessible document, although it is geared towards clinicians. And there are other resources and materials that can be helpful for this as well. This is just another page of it. What you can see here is that there's a number of conditions that we see associated with an increased risk for hereditary endocrine tumors, and I'm going to talk about a few of them as we go. I'm going to start with the one which is where I do a lot of my research and see most of my patients for clinical care, which are pheochromocytoma and paraganglioma. This is a type of neuroendocrine tumor that arises anywhere from the base of the skull to below the pelvis, and can also happen in the adrenal medulla. This is not only one of my favorite pictures because it is from a book that was written by Dr. Fauci, but also because I think it does a really nice job of showing where paragangliomas and pheochromocytomas can arise. You can see here on the right that we see a number of areas that are kind of shaded in red that you can see these tumors develop in. And also in the middle picture, the areas in red are where they can show up anywhere in this chain on either side of your spine, as mentioned, from the base of the skull all the way down to below the bladder. And what this means is that patients can get tumors in lots of different areas and need lots of different multi-specialty care. So some of you may be on this call seeing a provider who specializes in gastroenterology, oncology, and some of you may be seeing someone who specializes in the head, neck, and urology, et cetera. So just important to note that these kinds of tumors, because they can happen all over the body, people have very different experiences, but they also can be called different things. So this is just another close-up of the head and neck. What you can see here, the glomus tympanicum, the glomus jugulare, and the carotid body tumor. These are three of the most common places that we see paragangliomas arise in the head and neck area. And again, that specialist involvement is going to vary by location, which is also worth noting because people work in different specialties and with different kind of considerations of who might need genetic testing. So it never hurts to ask your doctor if this is something that they might consider for you. And if you are somebody with a paraganglioma, as I'm going to talk about, you definitely are recommended to get genetic testing, and I'll talk more about why in a second. I like to just walk over this. I show this to providers when I give talks to them, and I think it's helpful for patients to understand as well. If this is a kind of tumor that that affects you, you'll know that there's kind of two different types. I like to call kind of the top half, kind of from this area up. This is what we think of as more of our rest and digest system. And when tumors grow along here, they don't necessarily cause any hormone excess, but because we have so many things that take up space in our head and neck area, it's not uncommon for us to see mass effect or things where we see a tumor pressing on any of these areas and resulting in headaches, dizziness, things like that when we're having kind of extra things in our head and neck than we would expect to see. On the other hand, in the bottom half of our body, we see things, tumors that can grow kind of along that fight or flight nervous system. So I liken this to being chased by a bear. Sometimes people feel like they're having kind of heart racing in the middle of a sad movie, and that's because there's extra hormones being secreted in the body, and that's resulting in those fight or flight symptoms. Again, these are in a different area of the body as well. Either way, anybody who's diagnosed with one of these tumors needs genetic testing. As you've heard me talk about, only 5 to 10% of tumors have a hereditary cause, but in paragangliomas, we find a hereditary cause anywhere from 25 to 60% of the time. A study done a few years ago by Dr. Lauren Fishbein looked at a number of patients at their institution and found 41% of them had genetic mutations or germline findings. And that's really important, again, because that number in paragangliomas is much higher than the general population. And as a result, it's a standard guideline for all patients with any of these tumors to undergo genetic testing. Now, you might be thinking, why are we doing that? What are we looking for? When we see any paraganglioma that's undergoing genetic testing, we're typically looking at about 13 to 15 genes, 12 to 14, depends on what lab you're looking at. There are some recent additions. So here on the right, you can see a graph showing when we identified each of the genes that we associate with an increased risk for pheochromocytoma and or paraganglioma. 3 of them have been added recently. You can see some of them identified in the early 2010s and some that we've only recently found in association with paraganglioma. There are about 20 to 25 genes that we can test for, but they're not typically clinically available at this time, although we expect that to change soon. So if you are someone who had genetic testing in the early to mid 2000s, it may be beneficial to think about getting genetic testing again because of the new genes that we've discovered and new findings. It's worth noting that if you have a pheochromocytoma, which is the tumor in the adrenal glands, that is associated with many of the genes that we see here. Whereas people with paragangliomas outside of the adrenal glands are more likely to have a genetic change in the SDH genes that we can kind of see there clumped in the middle. And I'm going to talk about both of those as we go. Speaking of, let me talk about the SDH genes right now. So these are a complex that we see function together. You can see in the top left how that complex comes together to really function. But as a result, depending on where a genetic mutation is found, depends on the risk. So you can see just like SDH A, B, C, and D look to have different roles in this picture, they also have different risks and presentations in the table on the right. You can see those risks are as low as 10 to 15% and as high as 40 to 70%, although it's worth noting that a lot of the research that was done that first gave us some of these really high numbers, especially you can see here SDHB research as high as 70%, really happened in patients who had a tumor. And so once we started doing studies where we were looking at big families, where people didn't just have a tumor at the time of testing, but we were actually able to screen and see if they had tumors long-term, has really brought those numbers down. And I expect we're going to see a leveling off and kind of those ranges to get a little bit tighter over time. What you can also see here is the location. People with an SDHB genetic change are more likely to have tumors in their abdomen area, whereas people with C and D are more likely to have them in the head and neck. And there's variability across the board. In SDHB, we know there's a higher chance for malignancy or that those tumors could become cancer, whereas people with an SDHD genetic change are more likely to have multiple tumors than others with an SDH mutation. While the numbers that we still cite are around 10 to 15%, we think this number could be as low as about a 2% risk. And what that means is that we need to start thinking about how we take care of patients with an SDHA mutation versus an SDHD, because those risk numbers aren't necessarily created equal, and we need to be thinking about how we tailor risk to you as a patient and family. Also worth noting in the SDH complex, we see increased risks if someone has a mutation for gastrointestinal stromal tumors or GISTs, or renal cell carcinoma, also known as kidney cancer. There's other endocrine conditions, and the multiple endocrine neoplasia syndromes are a few of them. There are 3 types. You can see them here on the right. They vary by tumor risk, and they vary by tumor type. So when we're teaching students about multiple endocrine neoplasia type 1, we talk about the 3 Ps: pituitary adenoma, parathyroid, and pancreatic tumors. And then when we think about MEN2, we were really thinking about medullary thyroid cancer as a common condition that we see. But what you can see here is also risks for pheochromocytoma as well as parathyroid risk as well. And the numbers I've included here on the left, these come straight from NCCN. This can be beneficial to think about because I think oftentimes we hear multiple endocrine neoplasia, and right now there's that commercial that talks about not doing a treatment if you do have multiple endocrine neoplasia. So we're really starting to see this come more into the mainstream, and I think it's important to just note that these three conditions are quite different in their presentation and how we manage them. So knowing whether you have a multiple endocrine neoplasia syndrome is important, and also knowing what type, similar to the SDHs. Another condition associated with neuroendocrine tumors, not just pheochromocytomas, but also pancreatic NETs or PNETs, is von Hippel-Lindau. This is a multi-system condition associated with increased risks for what we call hemangioblastomas, which are small tumors that can grow in the brain, spinal cord, or on the eyes, as well as increased risks for kidney cancer, pheochromocytomas, and those pancreatic neuroendocrine tumors. You can see here on the right, this is just a broad overview that most commonly we see these diagnosed as early as when kids are in their teens, and that we can see a variable frequency of each of these conditions. So if you look towards the middle of that viscera section, the pancreatic tumor or cysts, you can see a pretty wide range of risk from 35 to 70%. But you can also see a pretty wide age range of presentation, but that most people are diagnosed with these in their 20s and 30s. So if you were someone who had a pancreatic neuroendocrine tumor, we would also potentially look to see if there were other tumors that we might be suspicious for von Hippel-Lindau, or we could evaluate this using genetic testing. If you are someone with von Hippel-Lindau, my favorite resource is that the Von Hippel-Lindau Alliance, or VHLA, has a handbook that is free for patients, caretakers, families, and providers. It is my favorite tool. It's free to download, and I highly recommend it. I've talked about some of the conditions that we could see, but I want to talk about some of the logistics. When we think about genetic testing, sometimes I still get asked about Gattaca or other things. And the reality is that genetic testing is nothing like we see in the movies or TV shows, but it's also much more simple and more accessible than it used to be. Typically, genetic testing is done with a blood or a saliva sample with a 3 to 4 week turnaround time. There are multiple labs and testing options, and I'm including just one lab in the bottom left. These are all of the cancer tests that they offer. And as you can see, there's wide variability in not only what they find, but what they test for and different cancer types. But I'm purposely not zooming in on this because this is not a branded presentation. There are lots of labs that we use clinically, and this is just a graphic to give you an example of how variable testing options can be. Genetic counseling and testing are separate services. You would come to see a genetic counselor who could then help facilitate a genetic test, but most insurances cover both. When we think about genetic testing, each insurance has their own testing criteria, but most follow Medicare or NCCN, which is what I previously showed earlier. Most laboratories take care of pre-authorizations, and there's options for self-pay and those with poor insurance coverage to get genetic testing. The self-pay cost at most labs nowadays is $250 or less, and that means that testing is more accessible than ever. On the other hand, I want to acknowledge that $250 can also be a lot of money. And there are really great financial assistance options if you're someone who think you might meet these criteria for testing, but may not have the means. It's worth talking with somebody to figure that out. They don't use your typical thresholds. Their thresholds for covering testing are actually much better than other coverage plans. I also want to just note that there is this 3 to 4 week turnaround time, and that typically allows time for the labs to work with you to work out the financial options. They're all pretty financially transparent, and most of our patients pay less than $100, at least in my experience clinically. So while we give these numbers, they can often be quite affordable, and many of our patients pay nothing at all, especially when they meet criteria. So I want to talk a little bit about why we do all of this. And I highlighted it at the beginning, which is that when someone has a genetic mutation, we change screening. The recommendations differ by condition and individual history, and I don't expect you to look very hard at either of these, but what I want to really highlight is that there's lots of different recommendations. And this top one is for the SDH genes. This is one that came out about 5 years ago. And then the one in the bottom is the most recent von Hippel-Lindau recommendations that came out from the VHL Alliance. One of the best things about NCCN and this expert group coming together to make recommendations is that they've really been a place to bring together all of the different papers that have recommendations for patients. And so while both of these are guidelines that came out from an expert consensus and not from NCCN, These are the recommendations that have been adopted by NCCN to help with insurance coverage and really bring providers together to recommend the same care for people that have a hereditary risk. I want to talk a little bit about this because this is a new addition and there's a lot to see, but I'm actually just going to draw your attention to the bottom bullet point that says, since SDH genes have variability in their tumor penetrance and risk for malignancy, consideration can be given to modified screening intervals, especially for less penetrant genes. And you might be wondering, what does that mean for me? What it means is that especially in the SDH genes, we treat everyone the same, whether you have a 5% risk for a tumor or a 60% risk for a tumor, which is kind of the very high end. We do our management the same way. We do imaging and blood work, and we do it at a certain frequency every few years. The reality is that if you have a 5% risk, we may not need to be doing that screening every 2 years compared to someone who has a much higher risk. Similarly, in SDHB, where people have an increased risk for malignancy or those tumors to be cancerous, we might want to be a little bit more cautious about how we screen and a little bit more proactive than we might for someone with a lower risk. What's nice about these guidelines is they really allow us to work with you as the patient to decide what to do. And this is a really nice thing. It can also be a blessing and a curse. But I really want to encourage you that if this is something that you're going through in your care, it can be really beneficial to really join into the process and be a part of that facilitated decision making because these guidelines are changing. And I would expect in the next few years that this talk, I hope, knock on wood, is outdated because we have gene-specific guidelines that we know the right way to take care of SDHA versus B versus C versus D. And the same thing goes for von Hippel-Lindau. There's a few different types of von Hippel-Lindau, and right now we recommend the same screening. We hope that down the road, we're able to say you have this type. These are the recommendations we want to make. In the multiple endocrine neoplasia type 1 realm, if you have type 1, you have specific recommendations. They're very clear and they've been decided upon. Multiple endocrine neoplasia, or MEN type 1, is really kind of been a hallmark and one that we want to use when we think about what we do for conditions that we're continuing to learn more about. Coming back here, these are the guidelines for a number of the conditions. You can see here, this is the SDH genes, MEN type 2, von Hippel-Lindau, et cetera. And I want to just bring attention to this because, again, NCCN is provider focused, but if you were looking to see what providers are being told or recommended by NCCN, you're welcome to get a free account and check these out yourself. So in summary, I think certain types of neuroendocrine tumors and family history warrant genetic counseling and testing, but there's many hereditary syndromes, and genetic testing can help identify whether something's happening in your family. It's also worth noting, as I mentioned before, if you have a family history of breast, colon, ovarian, pancreatic, prostate, et cetera, it may be worth talking with a genetic specialist. Though none of the endocrine conditions have necessarily a risk for any of the cancers I just listed, there are other conditions that put people at increased risk for breast, colon, et cetera. And as a result, doing a broader type of genetic testing can make sure that we're assessing you and your family risk to make sure that we're getting everything tested and worked up that we should. As I noted before, you may be getting other types of genetic testing that we can find a hereditary risk in you. And if that's the case, definitely talk with your doctor and or a genetic specialist. We're always happy to help. And finding a hereditary cause can change not only your treatment, but also potentially screening of other family members. We're here as genetic specialists to be a resource, whether it's a genetic counselor, someone who specializes in genetics within your care team, you name it, that's part of our role, and we're always available. If you don't know where there's a genetic counselor near you, there's a great website, findageneticcounselor.com. You put in your zip code and what you're looking for. In this case, you would choose cancer or oncology as the specialty, and find somebody in your area that you might be able to talk with. But more than that, what I hope you've heard me talk about is the importance of multidisciplinary teams in this care. Genetics is just one piece of an overall process when you're going through treatment, and walking through that with whoever the right people are to be involved in your care and making sure they have the expertise to take care of you is the most important part. As a result, I'm always available, and there are a number of genetic counselors who have these kinds of interests and are always happy to help, not only on that website, but I'll provide my contact information as well, because helping get you connected to the right care is one of our top priorities as clinicians. So with that, I am really looking forward to the Q&A. I want to thank LACNETS for having me. My email address is here, but I can also be reached on Twitter, and I'm more than happy to chat about any questions that you may have.
Welcome back, and thank you so much for that excellent presentation. I know that for me, as someone who is living with NET with my husband who has NET, this is an area that I might have kind of neglected, honestly. I might put a lot of attention into treatments and all the clinical stuff, but this whole area is just kind of vague and unknown, a lot of unknowns. So I'm really grateful to you for bringing a lot of clarity to this area.
Thank you for having me. It's really exciting to be here and be able to talk with our community about the genetic side of things.
Yeah. Actually, before we get started, may I just ask you to share a little bit about what made you switch from being a 7th grade teacher to become a genetic counselor?
Yeah, that's a great question. So I actually had a moment in my first year of teaching. We were learning about the human body and genetics, and I'd always thought I wanted to be a genetic counselor, but knew I wanted to pursue other kind of this teaching profession and tell myself like, okay, if you really want to go into genetic counseling, you've tried the teaching route. And about halfway through my first year, my students said to me, Miss Greenberg, why are you teaching us? Why aren't you a doctor? And that was actually the moment that I needed to show me that I was better doing education in healthcare. And that's what I have loved about genetic counseling. And now in this new role, really getting to work with students and continue research while building a training program, is that education is at the heart of genetic counseling. It's at the heart of 7th grade. It's at the heart of these webinars. And it's been something that's really been meaningful for me to think about how we give back and how we increase awareness, especially about these topics. You didn't ask this, but I'll share really briefly. My graduate training is actually where I started to have interest in NETs. And I had a very large family that I was doing the behind the scenes prep work for, and watching that family grow and identify who had genetic changes, who was at risk, where kind of their screening and such was going to take place, was really what inspired me to get interested in the neuroendocrine side of things. And then I feel really fortunate to have had great mentorship throughout the beginning of my career that's helped supported this unique interest in neuroendocrine tumor genetics.
Wow. We're so grateful to you for being interested in it, for meeting with patients, and that there are people like you out there is very hopeful to us, and that you're training more people like you.
Yes.
So we have a lot of questions that have been trickling in. So if we can, we'll just jump right into it. So the first question that came up is, I have my raw DNA from a DNA test. Can I just look it up myself?
This is a great question, and the answer is yes and no. So there are websites for many of you that may have raw data from 23andMe, Ancestry, you name it, that websites that are willing to kind of process that data. There's a few key pieces about this. The first is that when we think about genetic testing in our world, germline testing is looking at the whole gene. Every letter is something misspelled, added, missing, you name it. And in Ancestry, 23andMe, et cetera, oftentimes what they're doing is looking at 7 spots in that gene rather than the whole thing. And so there's a difference in the type of testing, and what we can find is that people who use raw data as a standalone may miss something that exists that isn't being tested for in that data. That's not necessarily what those tests are built for. So that's kind of the first part of this. But the second part is that there are some genetic findings that can be identified in those 23andMe and Ancestry. And while the technology and those raw databases have really come a long way, I highly encourage people to make sure that if they find something, that they go to a genetic counselor or genetic specialist or their doctor, have it clinically confirmed. A number of times, based on the technology and the way that it's done, that genetic finding in the raw database may not actually be what we call a clinically true finding. And that's due to differences in the validation of the technology and other things. So I really encourage people, those databases are very neat. And once in a blue moon, they do turn out to kind of have that tight correlation. But you want to make sure that you're seeing someone that can do a full analysis and that you're not missing anything or overly relying on a piece of information that may actually not be as thorough as you need it to be.
Thank you for explaining that, because I know that that is very popular right now. A somewhat related question, how accurate are genetic testing results? Do they sometimes have error, false positives, or false negatives?
I would say that genetic test results overall are accurate. So the threshold, and this is again where some things differ, although raw data and your direct to consumer 23andMe, et cetera, do have pretty good standards, there's a different set that we use in the clinical testing realm. We want to make sure that the rate of getting a false positive and a false negative are very, very low. And that's because if you get a false positive and we start screening you for something that you don't need, we're not using resources appropriately, or we're over worrying you for things that you don't need to be worried about. And on the other side, in a false negative, we end up with information that we assume to be, oh, we don't need extra screening when we really do. So it is really important to us that genetic testing results are accurate. And the thing I didn't go into is that we have positive and negative, but in the middle, we have what's called a variant of uncertain significance. And this is any time that we aren't immediately sure it's positive or negative, we end up with an uncertain result. And that's because, as I mentioned before, we have millions of genetic changes, but most of them don't impact our health. And over 90% of the time, uncertain results do turn out to be negative. So I make that note because the most common thing that we see is uncertain results moving to either positive or negative, which is the most likely scenario. And so we truly trust genetic testing results. There are very few scenarios where we've seen false positives or false negatives, and those are typically due to lab error and happen very, very rarely.
And the variant of uncertain significance, that shows up as VUS.
Yeah, and we do see those about 20 to 25% of the time, right? Because we don't want to plant our flag inaccurately or positive or negative, this uncertain area is one that is not uncommon to see, to make sure that we're giving patients as much information as possible.
You mentioned that there were a lot of different labs and testing. What are the pros and cons of sequencing NGS, WGS, or WES versus panels? And is one panel better than another? For example, Invitae, Foundation Med, MSK Impact, Mayo Clinic, MDH Health. And if you could explain the NGS, WGS.
Yes. Yeah, yes. I was going to say, let me start there. So NGS is our next generation sequencing. So if you look at the cost of genetic testing, it's drastically fallen over the last few decades due to new technological innovations like next generation sequencing. Now, the next generation sequencing is a technique that we use on panels and on WGS and WES, which I'll talk about in a second. But just worth noting that NGS is kind of the underlying tool. Now, next generation sequencing is not perfect, and the bounds of next generation sequencing is also variable. And so I'll talk about in response to the second question as well. So WGS is your whole genome sequencing, WES is your whole exome sequencing, and then panels is what we currently order. So right now, we order anywhere from 15 to about 70-ish genes associated with an increased risk for neuroendocrine tumors and or other cancers. So if I have a patient that has a family history of breast cancer and they themselves have a neuroendocrine tumor, I'm probably doing that larger panel because the cost of running them is actually very similar, if not the same. And we want to work with patients to understand how much information they want. And oftentimes a family history of breast cancer meets its own criteria, so we want to test for multiple things. When it comes to whole genome and whole exome, that is not something that is commonly done clinically in a cancer or tumor setting. Now, it is being done in other specialties and other settings. And without going too far down that rabbit hole, working with a genetic specialist can really help you navigate what the right scenario is for you as a patient. But in the cancer and tumor realm, we're still in panels. The reason for that is that we don't see as much of that connection to kind of new genes associated with increased risk, and the data is still pretty unknown. And in response to the second question, is one panel better than the others? They are all equivalent in the germline realm and then all equivalent in the somatic realm, or that tumor realm. And what you're actually seeing is Foundation, MSK Impact. Some of those are just tumor. Invitae right now is just germline, or those healthy cells that you've had since the day you're born. Some of the labs offer both. And so I can only imagine how hard it is as a patient to navigate these scenarios. And this is where really asking questions and helping understand what kind of testing you've had done. Is one panel better than another? The answer is really that it depends. And I could give a whole nother talk on this. So I don't want to go too far down that rabbit hole.
Well, this leads to kind of naturally wonder about this other question. Should NET patients repeat genetic testing? And if so, when or how often? And does it matter if they repeat with the same lab or with different one?
So I would say that the answer is maybe. So germline genetic testing doesn't change. You have the same cells and the same genetic code in your body since the day you were born. And the only difference that really changes is how much we know. So you heard me talk earlier that it can be really beneficial, and we anticipate there might be new genetic testing coming down the pipeline. I've heard rumors of a specific neuroendocrine tumor panel, which we don't necessarily have in many clinical settings right now. And so when that becomes available, it's probably worth checking with your provider to see if you need new follow-up testing. But you don't need new testing because your genetic code has necessarily changed. That can be different in the tumor realm. Your doctor may recommend doing another set of tests, and that's again because your tumor is an accumulation of genetic changes over time. And identifying which of those genetic changes you may or may not have, or your tumor may or may not have, is going to be impactful for treatment. So you shouldn't repeat genetic testing unless there's something new to look for, or your doctor recommends it in the tumor-specific type of testing. And whether or not you repeat with the same lab or a different one typically doesn't matter, as long as they're one that offers new things that you're looking for. It's very rare within a short period of time to do repeat testing at the same lab or different labs. And that's also related to insurance coverage.
Well, speaking of insurance, there's several questions and it sounds expensive, right, to get genetic testing. So I know you touched on this a little bit, but is there a way to get genetic testing done if you can't afford to pay out of pocket?
So there are some studies, although I don't recommend. Usually we say find clinical research that's your best route, and it's not that isn't your best route. It's just that there's not a ton of these that are widely available, and so searching for a research trial is going to take more time than reaching out or looking at patient assistance plans at a place like Invitae, Ambry, Myriad, et cetera. The threshold is often pretty high, and when I have patients who cannot afford out-of-pocket costs, oftentimes the financial assistant plans do cover them, and most patients end up paying nothing out of pocket. Now, genetic counseling can be its own billing, and so looking into that can be important, but there are a number of institutions or places that don't bill, especially right now. Billing reimbursement is hit or miss in genetic counseling, depending on how things are being billed. And so there are a number of places that have really low barriers to entry because we know that not everyone can afford to pay out of pocket.
And what about the insurance coverage potential? So could positive genetic mutation impact insurance coverage potential?
Yes and no. So I think that this is always a great question because it focuses on what is the long term, and it acknowledges or doesn't acknowledge that we've had a lot of healthcare reform in the last decade plus. So let me talk really broadly about the Genetic Information Non-Discrimination Act, or GINA. This is something that came out, was a bipartisan bill, came out in the Bush era and then was signed in the Obama era. I believe there might be somebody in there who is a better historian than I am. But suffice it to say, this bipartisan bill that basically said you shouldn't be hired, fired, promoted, demoted. So you shouldn't have your job status impacted by genetics, nor should your insurance drop you or change your rates. Essentially, if we think about the world back when we had pre-existing conditions, genetic testing is not legally allowed to be considered a pre-existing condition. Now, for many people who may be undergoing testing, they may have a neuroendocrine tumor or already have some strong family history. And so those can be factored in to things like life insurance, long-term care, and disability. And we see that often with genetic testing as well. But I find that when patients have a tumor or a cancer diagnosis, oftentimes their insurance coverage for long-term care, life, and disability is not typically impacted because they have other things going on that impact it above and beyond that genetic test result. It is beneficial for family though. So if you are 20-something years old, haven't really thought about life insurance, that is a conversation that we have with patients just to make sure that they've thought through it and what that might look like.
That's really helpful. And speaking of family, could genetic testing of my children show net potential and be part of their medical record that increases their insurance rates or make it harder for them to get it?
So this is where I think the delineation between someone with a tumor getting tested and someone without a tumor getting tested. Technically, it should not impact their insurance rates, right? It cannot be considered a pre-existing condition. Could it impact other rates, life insurance, et cetera? It's possible. And right now we're in a state of healthcare reform that most people are not currently allowed to consider pre-existing conditions when setting insurance rates. There's also, I'll just kind of put it out there, the next discussion that's being had is about genetic testing as a part of employee programs and laws surrounding that, and some concerns that as we build genetic testing into more parts of healthcare, that law may not continue to hold. But considering we're about 15 years in, about 10 plus years since it was signed, and we've been through so much healthcare reform and challenges to that reform, I feel pretty confident that increase of insurance rates, no, but impact on other non-insurance related items like disability, long-term care, et cetera, could be impacted. The question then becomes, what is the benefit versus the risk? And how do we adequately prepare? If there is a large increase of risk and we need a patient to undergo screening, it's probably better to deal with some of the nuances of insurance than to have a tumor diagnosis that could have been picked up early or prevented long term. And so when we think about guidance for genetic testing in adults and kids, we start with the person who has a tumor diagnosis. They're the ideal person. Then we want to look at their first degree relatives, kids, parents, and siblings, because they have a 50-50 chance of having that same genetic change. And then we want to expand to other relatives. And the benefits are early detection. So if we think about, if you are someone with a neuroendocrine tumor, think about the symptoms or how it was diagnosed. In people who have something diagnosed before those symptoms, we're able to avoid that process and really be proactive in care. And I like to tell kids, really maintain their quality of life, right? What we're going to add is a doctor's visit, a special thing that they get to come to with family, but that we're keeping them healthy just like everyone else who goes to the doctor for checkups. And then the risks are really thinking about, there are some downsides to thinking about life insurance and those kinds of things. And there's a lot of tools for us to help work through it. And so we work to really help maximize the benefit and mitigate the risks for when someone's making a decision. But that would be the guidance, is to start with someone who has a tumor. And if you identify a genetic change, then start with the most immediate family and work your way outwards.
And you started talking about kids. What advice and recommendations you have about discussing genetic testing with their children?
So I actually have a great resource. If you Google, it's St. Jude VHL conference. It actually pulls up a workshop that a number of speakers presented at about 13, 15 months ago. And one of the talks that I gave was actually about how to talk with kids about genetic testing. And also, if you have someone who's in an adolescent age or a kid moving into that age, how do you start to empower them to take ownership of this process, right? If you test your 6-year-old, the capacity they're going to have to manage their care is quite different than if they're 15. There's also a few webinars on the TheoPara Alliance website about how to talk with your kids about genetic testing if you have had a genetic change. But the summaries of those, if you want to learn more, there's whole webinars on them, and you get to see my shining face again. But when it comes to discussing genetic testing, the thing that I'd highlight is that what you are thinking about is often not necessarily what your child needs to know, but it's also not what you need to hide from them. So we will often talk about doing a blood test to see if they need to come to the doctor the same that mom or dad does, or another relative in the family. Or remember how grandpa was really sick the other day? We want to see if you, we want to make sure that that doesn't happen to you, right? So really framing this in a purpose that's beneficial for their health, entailing what's going to happen, saliva or a blood draw, and then really thinking about how we talk about tumors. So oftentimes for kids in clinic, I'll pull up a picture, and this is something you can work with your provider about. I'll pull up a picture of the parent who's had screening, and we'll say, what are those? That's a heart. What are those? That's a lung. What are these? Right? And help them really start to understand what screening looks like, that we're going to take pictures of the insides of their body, or that we want to keep them healthy because dad needed that surgery and we don't want that to happen to you. So really bringing it down to their level while not hiding things, to me, is the most important part about discussing genetic testing and assessing where your child's at, because every child is at a different place, age, developmentally, et cetera.
Those sound like really helpful videos and resources to have. Yeah, thank you for that. What about adult children? Should adult children with a parent living with NETs go through genetic testing?
Again, so this is a kind of a great reminder. Adults, child, kind of no matter where you're at, if somebody is living with a neuroendocrine tumor, they are the best person to undergo testing. And that's because even though you guys might be closely related, you're only 50% the same. So there's a possibility that you could get a negative genetic test and your parent who has the tumor could have a positive genetic test because their genetic change or mutation was in the 50% that you didn't inherit. And so making sure that you're starting with that person. If not, like if that person is not available, then we definitely would look to test adult children and kind of walk through that process.
What about two siblings? If they both have NET, should they get genetic testing?
I'm actually in the process of teaching our cancer genetics class still with our University of Utah program. And these are the kinds of challenges that we talk about, not because the situation itself is challenging, but in my eyes, there's really a gray zone between the guidelines that I've laid out and someone who has no history or someone who has one neuroendocrine tumor that isn't currently indicated. Right? We often don't see multiple people in a family with neuroendocrine tumors. So this is something that I often recommend to people. It's worth talking to somebody, working with a genetic counselor or another genetic specialist, seeing if they think it would be beneficial or thinking about the kind of information that you're looking for, while also acknowledging that that testing may have different coverage ability than someone who's got kind of a clear-cut diagnosis. In my eyes, when we see, because neuroendocrine tumors are not that common, seeing two people with a neuroendocrine tumor each would lead me to suggest genetic testing. What I'd probably do is, if we go back to that idea of people with a tumor, we then want to look for the next thing that's most suspicious. And that's often early age of diagnosis, someone with a multifocal neuroendocrine tumor, someone with multiple neuroendocrine tumors, separate primary or different tumors. So if one sibling had that and the other sibling had a standalone tumor at an older age, I'd probably test that first person that's had higher, kind of earlier ages of diagnosis and a stronger presentation of neuroendocrine tumors. If they were negative, I might still look to test that other relative. But just so you know, some providers will say, let's test both at once, and some will do it in order, and that's the reasoning behind it, is you often want to maximize genetic testing for who you think is the most likely to have that genetic change.
And this, you may have already answered it, but you mentioned MEN, so multiple endocrine neoplasia. So if someone tests positive for MEN1, which family members should also be tested? Children, siblings, parents, and then what about aunts, uncles, or cousins?
I feel like these questions were just perfectly teed up for me. So I agree. Children, siblings, and parents are first. You may be in a scenario, and it often happens, that there are no living relatives between you and your cousins, or we don't have a way to know which side of the family it comes from. That's why testing parents is the most ideal scenario, because it allows us to eliminate one whole side of aunts, uncles, cousins, etc. But if that's not possible, then it is really reasonable. You want to move from parents. Okay, if they're not available, aunts and uncles, if they're not available, then down to cousins. And I'm kind of drawing how they look in our pedigree that I can see in my head. So I would say that is the order you want to go in, is the closest degree of relationship that is living and available. And most genetic testing labs actually offer free testing if a genetic change has been identified within the first 90-ish days. And that has really allowed families to say, okay, we don't know which side, let's get all the cousins tested if no one else is available until we can find which side of the family that comes from.
Yeah, that's helpful. What if a NET patient's childless and doesn't have surviving blood-related family members? Does genetic testing make sense at all?
We get a lot of these questions, and I think in general, genetic testing is a personal decision, right? We have lots of patients and families and people who say, I don't know if I want X or Y or Z or what exactly I want to do, and that's totally reasonable. Some people feel like it's part of their familial obligation, and others feel like it's not. And this is part of what talking with someone in genetics can be helpful for, and talking with your doctor. There are some settings where people say genetic testing is super helpful because it's going to help me figure out if I have future risks and or if I can find an explanation that might help target treatment. But for you, if those two things aren't the case, let's say, and I hope not, but let's say we have a terminal diagnosis, or we are within the last few years of life, learning about a risk for other tumors down the road may not feel nearly as impactful as somebody who's kind of been diagnosed with a neuroendocrine tumor and is not experiencing any symptoms or impact to their life because of it and have 30 plus years ahead. So that's a personal decision, but I'd say the reasons to get genetic testing, if you are in that scenario without family, is really related to if it could impact your treatment and if it could kind of identify other screenings that you may need to prevent this from happening in the future if there were other tumor risks associated with that condition.
Thank you. Well, you're doing a fantastic job asking hard questions. So this This may be a hard one for you. Can you do genetic testing on relatives that have died? For example, now knowing that a parent has NETs, perhaps a brother or fathers were the same.
The answer is maybe. So testing on relatives that have passed is often complicated unless you've done something like blood banking or something in advance. So I'm going to kind of break it up into the three categories that I think people may fall into. The first is if you are someone, best case scenario, you have done some kind of biobanking ahead of time, you have that available, then yes, you can do genetic testing on relatives that have died. They end up in that $250 self-pay range, and this is definitely something that you want to coordinate with a genetic specialist to really walk you through the process. I think the question particular to that is if a parent has NETs, brothers and fathers were the same, what is kind of the purpose, right? Is it to test a brother because they have 9 children, and rather than test all 9, you could test one brother to figure out if you needed it? That would be a really beneficial use. On the other hand, if there's 1 or 2 children, then maybe just moving to their family members could be beneficial. The second scenario is you don't have any of that, and or someone has passed kind of pretty quickly, and you were able to maybe get blood at the time of their passing or something along those lines. In some of those scenarios, you can send genetic testing. In other scenarios, we look to test family to get the most information. And then the third scenario, and I have to be honest, I do not know of this that often in neuroendocrine tumors. It is not super common, but it does happen on rare occasion, which is if a patient who has passed has a tissue sample from their tumor available, and they have tissue that's been banked, like from a surgery or something, from healthy tissue, once in a while you can do testing on both and do a comparison. Again, the reason and the need for this is typically a much higher bar than the first two that I talked about as well. There are a lot of steps to that process, and it's typically not done, but never say never. So I just want to put that out there that that's kind of the lay of the land, but it is highly variable right now.
And this question is a little bit specific, but let's just take it as an example of that question that was just asked. So say this is my daughter that was diagnosed with small cell neuroendocrine carcinoma at age 24, and she passed, unfortunately. We can't find the postmortem testing for the trio WGS or WES. Can you help?
Probably not me, but there might be someone who can. So let me talk a little bit. We talked about whole genome and whole exome sequencing a few questions ago, and I did not totally go through it. So in whole exon sequencing, whole exome sequencing, WES, rather than just look at the genes associated with an increased risk, we're looking at all, multiple thousands of genes to see if there's anything added or missing. And then whole genome sequencing is going to be looking at the entire sequence. Exome is just looking at the genetic code that codes for things in our body, and whole genome sequencing is looking at all the parts of it, even things that don't necessarily immediately code into a protein that we talked about in the beginning. I typically don't see a lot of trio testing in these settings and or in postmortem settings for a number of reasons. Honestly, cost being a huge prohibitive step to this. I'm sure it is available, but thinking about what kinds of tissue exist and what kinds of comparisons would need to be done, and then the quality of that material are all questions that go into that overall process. I would say, and you're welcome to email me, I would have to ask some other people about it to get a better answer about actually being able to help, but I would say in general, that's not a super common scenario for kind of all the reasons we've just talked about.
Okay, thank you. Can hereditary mutations have external origins, such as parents' exposure to toxins like Agent Orange? And is there research on origins of mutations outside of lineages?
Yeah, that's a good question. So yes and no. I feel like that's become my answer for a number of these. So we know that there are specific environmental and other exposures that put people at increased risk for cancer, right? We see it right now with Agent Orange and prostate cancer. We see it in other settings. But the reality is that most genetic changes have been happening for generations and many, many more years than we had genetic testing or even probably knew what cancer was. So when we think about research on the origin outside of lineages, honestly, it can be random changes. We call those de novo, where someone is the first in their family to have a genetic change. This is more common in conditions like von Hippel-Lindau. I think it's 10 to 20% of those patients have a de novo change. It is significantly less common in genes like the SDH gene. And the reason for that honestly has to do with the age of onset, the aggressiveness of the tumor. Before we knew much about von Hippel-Lindau, patients often died of hemangioblastomas and renal cell carcinomas before they were able to reproduce. And so without getting too far down the rabbit hole, we look at things like reproductive fitness, et cetera, and we know that in conditions where patients are not able to reproduce before the condition leads to them passing, then there's a higher chance of de novo changes happening or new mutations coming into the setting. For something like Agent Orange, we're probably too soon into the timeline to really know what that risk has been like long term. So I would say stay tuned. There's definitely more research coming. And in general, most, with the exception of VHL, most are typically don't have new origins. They typically are something we've known about for a very, very, very long time. And you even see this in SDH, people with paragangliomas or pheochromocytomas, maybe in previous generations where someone died of a heart attack that may not have actually been a heart attack. So we're still in that era where our history of cancer is so young that it's going to take us a few more decades to really see what that looks like on a bigger scale.
Okay, well, we'll have to stay tuned or have you back to update us.
Yes, hopefully we'll have new information soon.
Yeah. If an adult child was diagnosed as a child with pancreatitis, would they have a greater chance of neuroendocrine cancer, and should they get genetic testing?
This is a tough one. So we do see patients with chronic pancreatitis or other conditions, and we do know that there can be some association between pancreatitis and pancreatic cancer. That being said, I am not a pancreas expert, and so I do not know if that's specific to adenocarcinomas or pancreatic neuroendocrine tumors. That being said, we do test people depending on their history of pancreatitis, how many bouts they've had, the ages that they had them. There are specific pancreatitis conditions that we think of that may be worth testing for. Worth noting that those are in a different category than our cancer panel, but often we run both at the same time. So it's a little bit outside of the neuroendocrine realm for my knowledge scope, but that is something we do genetic testing for.
And again, this may be outside your realm, but can you, from a genetic counselor standpoint, could you explain the difference between pancreatic adenocarcinoma versus pancreatic NET and how it impacts that risk assessment and what's differential?
Yeah, I love this question. I can partially explain. So essentially, a pancreatic adenocarcinoma and a pancreatic neuroendocrine tumor arise from different types of tissue that exist in the pancreas, and they are different pathologically and in treatment. They also happen to be different from a genetic perspective, and so I'm going to focus on that because beyond understanding that small amount about the difference, I really am kind of based in that risk assessment. So recently we've discovered that about 8 to 12% of pancreatic adenocarcinomas have a hereditary underlying cause. If you are someone who has a first or second degree relative with pancreatic cancer, kind of the classic one that we think of, we do recommend testing, and the things that we think about are BRCA, CDKN2A, which is a condition associated with pancreatic cancer and melanoma, and then a number of what we call moderate risk genes that have been identified in the last 5 to 10 years where we do see increased risks. So one is like PALB2, we see increased risks for breast and pancreatic cancer, among other cancer types, et cetera. When I think about pancreatic neuroendocrine tumor, though, I shift that thinking. This is where I'm more so thinking about the endocrine conditions that I've talked about, your multiple endocrine neoplasia, your von Hippel-Lindau. And so if somebody has one of those tumor types, the conversations that we're having changes, and also the rate. So we're still really looking into and leaning into, in that PNET realm, what's on the differential and what's that likelihood of finding something. And I think that really speaks to the need and goal for us to really continue to increase rare cancers and increase research on rare cancers. We don't want to increase the cancers themselves, but the research and our background knowledge into them is something that we really need to be doing. And worth noting that the studies that have come out recently actually they don't exist anymore, but they used to do free testing for both pancreatic adenocarcinoma and pancreatic neuroendocrine tumors. So I do think we're in this space of really trying to understand the differences when it comes to genetics. But there is a pretty big difference when I think about the conditions that could be associated with each one.
Thank you. This is a good question. What gene variants are known to cause NET and NEC tissue specific, and how does this help in treatment? Any specific drugs for certain variants, and any good reviews?
Yes. I'm going to put in a pre-plug for my one of my colleagues, Dr. Eloisa Suarez, who is doing NET clinical trials next month, because I think she and Dr. Del Rivero and some incredible people are really the experts on this. I think we are just starting to dip our toes into this realm. So I want to give an example in the BRCA realm just to set the scene of where I hope we are headed in neuroendocrine and other realms, and then encourage you to tune in next month. So if somebody has a BRCA germline change in the BRCA1 or 2 or the BRCA genes, then we know that there are specific treatments called PARP inhibitors, olaparib, and other kinds that are really effective at treating those cancer types. But it is most effective in someone who has that genetic change in a BRCA gene. We expect and anticipate, and we're starting to get into that realm in other tumor types, including neuroendocrine and other tumor types. So it may or may not be tissue specific. It may or may not be variant specific. This is really, I've been so privileged over the last few years to work closely. It's very convenient that Dr. Suarez is right after, because I've been really lucky to work alongside them that have allowed my scope to stay in the genetic realm and to know that, yes, these things are coming down the pipeline, and to allow her to really kind of thrive in her expertise and be a great resource for you guys as well.
Yes, we're really excited about that. You mentioned the NCCN guidelines, and one person responded, why are not lung nets in the recommendations for genetic testing?
Good question. Probably because not enough research has been done. So typically what happens, and what it takes for something to get into recommendations, is typically a pretty robust study looking at a consecutive subset. So we don't bias for what kind of presentation someone has. We just say, okay, the next 500 lung neuroendocrine tumors, this is a very high number, but the next 500 lung neuroendocrine tumors that come through, we're going to do genetic testing, and then we're going to see what happens. And in those scenarios, then, we're able to say, okay, X% of people with lung nets have a genetic change, and therefore we should think about genetic testing. So there's kind of that threshold balance. And until that research happens in a way that the experts feel is robust, well done, and has impact, typically that's normally the deciding factor. So I would say it's probably due to a lack of research. And the other area that I think we're seeing change is, if you look at the people on the neuroendocrine tumor group, many of them focus on different areas within neuroendocrine tumors. And right now there's one genetic counselor there. And so while there are genetic guidelines and there are experts who do hereditary neuroendocrine things, you're looking at kind of within the expert group, a small subset, and then kind of them coming out with recommendations that they're then going to recommend to the broader group. And that's going to take more time than, say, a guideline about a specific neuroendocrine treatment, because that's something that more people on the committee are going to be engaged with. And I have not been on the committee, so this is just my speculation and things that I hear, but I think, we want that. We want people to make the right decision when it comes to recommendations, and we want to make sure that they feel like they've got the expert data. And so I'd say that overall is really what they're waiting for.
So more to come.
Yes.
You mentioned the variants of unknown significance. So can you talk more about it? What do they mean? How often are they updated? And how likely are they to contribute to NET?
Yeah, this is, I like this variety. There are some tough ones and I think some great ones, and this is both good and tough. So I'm going to talk a little bit more about variants of uncertain significance. I'm going to go back to that cookie analogy, right? If we think about, a change in the type of chip that's in your cookie, chocolate, peanut butter, you name it, right? It's still a cookie. You probably really enjoy it unless you're allergic to peanut butter. And that's kind of in that negative test result, right? We have lots of changes that make us us. If I go to the positive example, right, again, instead of flour, I have a double serving of sugar. That is not a good cookie. It may not even rise. Honestly, it may not even look like dough. Not that I've ever experienced that before. I have. But, right, you can tell there's a big change. That's that positive mutation that we see that isn't going to result in the outcome you want. And I liken a variant of uncertain significance to determining what's changed in the recipe and how significant it is. if I put macadamia nuts in my cookie and I put it in for a different type of nut, I probably still have a nut-based cookie. But if instead of baking soda, I put in baking powder, right? In some recipes, that's okay. Not a lot of recipes. And I'm not a total expert baker, so I apologize to anyone out there that I am like traumatizing based on my descriptions. But when I substitute baking soda for baking powder, right, oftentimes that makes a big difference in my chocolate chip cookie recipe. And so a variant of uncertain significance is saying, did I change the nut type and it's no big deal? Or is a small change like baking soda to baking powder actually a pretty big deal? And over 90% of the time, it's a small chip change. Chips, nuts, etc. Our body still functions like it needs to. And about 10% of the time, we do see that upgrade where something we say, okay, we thought it might have just been a small chip or nut change, and now we're actually looking at baking soda to baking powder or whatever that may be. And so to your answer about how likely they are to contribute to NETs, I'd say about 10, maybe 15% of the time, the NET genes are not quite as well studied and seen because it's a little bit more rare. And so slightly higher risk of kind of that upgrade to a positive genetic change rather than negative. But over 85 to 90% of the time, it's going to be negative. And typically, genetic specialists are going to use labs that auto update. So whenever that change happens, you get a notification. I probably, as a clinical counselor, got at least 3 to 5 a month that were changing. But this is going back to a way previous question about quality of labs. This is often a deciding factor as a genetic counselor because there are some labs that do not give you updates on these variants of uncertain significance. And that means that if you are in the 10 to 15%, you might not be getting that information. And we feel like that's really important. So while I'm just speaking for myself, I work with a lot of incredible genetic counselors who I know typically pick labs that do auto updates so that you are getting some kind of information. Now, some patients get that within 2 months and some get it within 2 years. And now I've been practicing for coming up on 7 years. And I have patients from my very first days that still have uncertain results. So the timeline of how often they're truly updated really depends on kind of how the data and research updates over time. And then the number of people that have that same genetic change over time that then dictate our ability to assess what proportion of people with that genetic change had tumors and does that track with the mutation. So it's a little bit more of a complicated answer, but the answer is yes, all of the above to your questions.
Yeah, thank you. This is an interesting question as well. It's actually 2 questions combined. Is genetic testing accurate for individuals of non-European descent? And are there ethnic groups linked to genetics? There was a little bit more detail about neurofibromatosis, paraganglioma in the family, and if it might be related to different ancestries.
Yeah, that's a good question. And, one I've actually been debating starting to add more succinctly into presentations because I do think we need to be talking about this. So genetic testing is accurate in individuals of non-European descent, but we have this horrible history of most of our research not being done in a representative sample. And what that means is that the rates of variants of uncertain significance are known to be higher in individuals of non-European descent. And the way that different labs and companies and organizations have chosen to address that, at least for me, have impacted who we use. And groups that have really been proactive to write and start to bridge some of that equity gap are ones for me personally that we like to use because this is a really important topic. And if you are someone, and I were to match you up of European and non-European descent and everything else was the same, we know that those individuals of non-European descent are going to have a higher variant of uncertain significance rate. And while we can work through that, that's not necessarily equitable. So the second question, so it's accurate, but the rate of uncertain results is a little bit higher. The second question, are ethnic groups linked? Yes and no. So we know that when individuals have Ashkenazi Jewish ancestry, rather than having 0.25% or 0.5% likelihood of a BRCA or BRCA mutation, they actually have about a 2% risk. So going from 1 in 400 to 1 in 40, I think I botched those percentages a little bit, but you get the 1 in 400 to 1 in 40 is kind of that number. So it's a 10-fold increase of Ashkenazi Jewish ancestry, and that's due to a number of reasons. The same thing can be said, there is a genetic change in a gene called CHEK2, which I haven't talked about at all, but we see a really common genetic change found in people of Polish ancestry, et cetera, et cetera. So are there ethnic groups? Yes. As a genetic counseling community, I think we're really moving away from asking about descent and ancestry, because while it can be beneficial, it no longer impacts the kind of clinical recommendations that we make for testing. And it really can unintentionally introduce additional bias. And so there are specific groups, and there is actually a paper just came out about a specific finding in an SGH gene that was identified in people of a specific background. And those are really helpful in research and in finding some of these, and in thinking, let's say you had that background and the lab didn't test for that genetic change, then you'd want to make sure that you went to a lab that did include that. But that's really the only purpose of using ancestry and or ethnicity at this time, because we want to make sure that we're pushing for equitable testing, and also that if somebody does have that unique background, that we're accounting for it, when the reality is we really want to encourage all labs to cover all of those things so that they are testing, accurately for all individuals.
Mm-hmm. This is a somewhat related question. How accurate is Ancestry DNA health test report?
That's a good question. So the Ancestry DNA health test, my understanding on the background end, and this is a little bit outside of my scope, my understanding is that what the testing that was done was often accurate, but the health test report varies by lab, and I would encourage you to talk with someone about the accuracy of it. For instance, 23andMe does have a few tests on their report that are validated and approved by the FDA. I'm not as familiar with all of Ancestry's. Again, they were around for a little bit shorter period of time. But I would talk with someone who can really look at the mechanisms of that. And that's where that Find a Genetic Counselor is going to be really beneficial, to kind of look and see what exists.
Okay. And speaking of, the just different variants of gene panels, do different countries have different gene panels that they test, or are these pretty much standard and shared among different nations?
I don't know the answer to that. I would say in general, we typically use similar panels. But the access and presentation of genetics in different countries is highly variable. And so thinking about what is happening in each country, I would say if somebody was getting testing for paraganglioma, neuroendocrine tumor, you name it, those 12 to 14 should be standard, right? And we'd want to push for those across the board. But I don't, like when we were just actually, Lisa was talking about Prague earlier, like when we were in Prague, there wasn't a large conversation about differences in testing. I think we all do things a little bit differently, but we also have different recommendations. So I talked a little bit about SDHA management, and our guidelines are starting to shift in their terminology, but over in specific places in Europe, they actually don't recommend screening if you find SDHA not related to a neuroendocrine tumor. So if you find, you have a test related to a breast cancer diagnosis and we find SDHA, they actually don't recommend screening, whereas we here do in the States. So there are a number of similarities, and I would hope that there's a lot of overlap. But we do a lot of collaboration internationally amongst our genetic counseling community to help find kind of answers to those. So I would check with your doctor and or someone else, and you or they are also welcome to contact me, see if we can't find someone in your area as well.
Great. Speaking of finding someone, what is the best way to find a genetic counselor appropriate for me? Do NET patients need to find a genetic counselor who is familiar with NET?
Yeah, so I would say, findageneticcounselor.com is the best resource. It is going to help you figure out virtual, in-person, locations, coverage, et cetera. And then just making sure you check that cancer box is going to be really important. That's the closest way to find a genetic counselor who's familiar with neuroendocrine tumor. This guideline and this recommendation is all fairly new. We've been talking about it for many years, but I want to say it's only 2 or 3 years old in the NCCN realm. And so what that means is that finding a genetic counselor who's familiar with neuroendocrine tumor is probably a very, very small subset for the kind of specialty that we often talk about when it comes to NET care. I am someone who is familiar with neuroendocrine tumors, as well as the team that I worked on at Huntsman and here now at UT Southwestern. But I wouldn't say that anybody has staked their claim that a large portion of their practice is this. And so using the FeelPara Alliance website to find those centers of excellence, finding net centers of excellence, which I know back in Utah, we just kind of went through our certification. Finding those centers of excellence are often going to have enough of a multidisciplinary team for you to find a genetic specialist who has enough background to work with you. And that's not to say that others don't. I work with lots of community genetic counselors and you name it, but that would be my top recommendation, is not necessarily finding a genetic counselor who's familiar with NET, but finding a center that is familiar with NET, and within there, they will have the genetic resources that you need.
Thank you. And we'll just end with this last question. What advances are on the horizon in the field of genetic testing that you're excited about and we should be aware of? And also just any last closing words of hope.
Okay. Oh, this is a great one. So I think, from a little birdie, that very soon we are going to have like a specific neuroendocrine tumor panel for germline testing that is going to not just, we'll have a pheochromocytoma paraganglioma one that is not the 12 to 14, but is more. And then we're going to have a neuroendocrine that's even more than that. And I will not give any information, but the people that tell me about this, I ask them every 1 to 2 months when it's coming. So I know it's coming soon. I just don't know exactly when. And I think this is going to usher in a huge world of information for our patients and their families to really help think about what we do and don't know and how we manage families. And the last thing I would say, just as far as hope and those kinds of things, is that, I actually shared this with Lisa earlier, that as a cancer patient myself who is now kind of out of the process for a few years, I think there are so many things that happen. And you are in the process, whether you are in it or in a maintenance phase or in a remission curative phase, wherever you may be, you're still going through a lot. And you're navigating, working with family, like your family, working with your providers, scheduling. You might be working with a jobs, like alongside friends to help you get places, or a job to help work while you're in the middle of these processes. There are a million things that happen. And so if you are someone who is looking at this and saying, man, I really wish I had had genetic testing earlier, or I should have done this 10 years ago, please know that it's okay. And we're thrilled that you're here and listening to this webinar right now, and that is the most important thing that you can do. And if you go home and you go back to all of those other stressors and life things, and in 3 months you think about genetic testing again, the genetic counselors and our genetics community is still going to be here. And that this is a part of the process. It is not something that is so important that we can't say, like, let's wait a month and do it. Is it important? Sure. Is it imperative? Yes. If you are on that criteria, we know that that's beneficial. But the most important thing is really taking care of yourself and partnering with the right people to get the care that you need to be able to do this long term, or for whatever period of time that you're going through. And that where you are is the right place to be, and that we are here to support you.
Well, thank you so much for those inspiring words. What a perfect way to close. And I just, your care and your passion is just so palpable. Thank you for all you do. Thank you for sharing your story. Thank you for being with us today and just sharing hope.
Yeah, thank you for having me. This has been a really great time.
We've really enjoyed it. And now I'm going to turn it back to Heather in the studio.
Thank you, Lisa. And thank you, Samantha, for that insightful presentation and addressing those questions from our audience. Follow us on social media to stay up to date on upcoming events and NET news. Our handle is @LACNETS. And now back to Lisa.
Thank you, Heather. We want you to know that you are not alone. And to this end, LACNETS offers many programs and resources, including our weekly virtual NET support group, our monthly caregiver-only support group, NET Vitals, our NET communication tool, and a health and wellness coaching program. We encourage you to go to our website, lacnets.org, to find out more information and resources. Thanks again to our supporters, Ipsen, Advanced Accelerator Applications, ITM Pharmaceuticals, and Lantheus. Thanks to our technical director, Rich, at TVP Live, and to all of you for joining us today. Goodbye, and see you next month.